Well, thank you very much. It's impressive to hear of all the progress in the other regions. So it's my turn to talk about the North America region. I'll talk about the disease burden, what has been done in the North American region, and where we are. These are my disclosures. So first, how common is hepatitis B and C in North America? Here's the data on hepatitis B, and this is taken from the study published in Lancet. So it's uniform how we got the data. And here you can see that prevalence of hepatitis B is higher in Canada, but very similar in Mexico and United States. It's overall very low prevalence, but it's not a small number. The prevalence of hepatitis C, unfortunately, the source of data is variable, so I don't really know how accurate each of these data set is. But it ranges between 1 to 1.5%. And I'll show you that at least in the United States, there are a lot of concerns about the accuracy of the data. So this is a little bit more details about the disease burden in the United States. Prevalence of hepatitis B, 0.3%, and hepatitis C, this is RNA positivity, about 1%. But as in other countries, less than half of the patients who are infected are aware that they're infected, and there continues to be a very high mortality, despite the fact that we have treatment available. And as we all know, the major concern is liver cancer. Whereas most cancers in the United States has been on the decline, but liver cancer has been on the increase in both men and women, and now liver cancer, which used to be extremely rare in the United States, is now the 6th cancer cause of death among men and the 9th cancer cause of death among women. So clearly we need to do a better job. Well, what about hepatitis B? Let's just focus on it for the time being. Over the decades, there's been a lot of initiative in terms of prevention by vaccinating high-risk groups and then offering vaccine to infants of HBs antigen-positive mothers, to universal vaccination of all newborns, as well as implementation of birth dose to every baby, regardless of the maternal status. And with all these initiatives by the CDC, there's been a very impressive decline in the incidence of new infection of hepatitis B in the United States. However, when you look at the prevalence of chronic hepatitis B infection, there hasn't been a big drop over the years. And the most impressive drop, as you would expect, is in the children and adolescents, whereas the prevalence among adults has not changed that much. In the most recent NHANES survey, thank God, Asians that have the highest prevalence of hepatitis B were included, and as we see, hepatitis B in the United States has a lot of racial disparities, with the foreign-born as well as some Asians and blacks having a higher prevalence. So it is something which is very important, because when we look at the global prevalence, it may be low, but there are specific groups in which it is common. And as we all sort of see, not just in the United States, but all over Europe as well, the number of new cases with chronic infection, many of them are not actually acquired within the country itself, but rather they are people who were born and who acquired the infections from the home countries where hepatitis B is endemic, and they immigrate with the infection status. Now, a lot of the data has been generated from modeling. This is real data acquired by the Hepatitis B Research Network, which is funded by the NIH, in which more than 1,600 adults with chronic hepatitis B infection in the United States, as well as in Toronto, Canada, were studied. And as you can see, 82% of the adult participants with chronic hepatitis B were actually born outside North America, with the majority being born in Asia, but a sizable proportion born in Africa as well. And there's major implication because obviously these people were infected with the HBV genotypes that are predominant in their home countries. And that creates some concerns about the clinical manifestations as well as our treatment strategies. As a result, in Canada, they also observed the same phenomenon, and there's been discussion as to whether we should be screening immigrants for hepatitis B. And modeling studies in Canada suggest that in general, screening for immigrants and connecting them to care, as well as offering vaccination to those adults who are not yet vaccinated, would be cost-effective, particularly with screening of younger people, as well as screening of people who come from most parts of the world, except for Latin America and the Middle East. This would largely be Asia, as well as African countries. This has been discussed in the United States, but it's not yet being adopted as a policy. We all know that hepatitis B can be prevented, and vaccine is very effective. But how good are we doing? We have policies, but in the real world, what's going on? And this is Canada, Mexico, and the United States in terms of coverage of 3-dose vaccines among infants. So it's pretty good in the United States and in Mexico, about 90%, somewhat lower in Canada for reasons that I'm not completely clear. But if we think of birth dose, which is the most important, since acquisition of infection in babies leads to a very high rate of chronic infection, unfortunately, we're not doing very well. Even in the United States, it's only about 70%. And data from Canada is not available. So much for infants, but coverage for vaccination among adults is even much lower. And disappointingly, even among healthcare workers, it's only about 60%. As a result of these inadequacies, the CDC actually modeled that we continue to have vertical transmission of hepatitis B, even in the United States, with roughly 800 to 1,000 infants estimated to be infected perinatally per year. This is something that we should and we can stop. As I indicated, vaccination and immunity among adults is very low. And in the United States, this is the most recent NHANES data, showing that among adults, overall, is only about 25% with immunity. So high immunity, and actually it's not that high. It's only about 45% among the adolescents, but dropping off to about 25% among adults in the range of 20 to 49. What are the implications? It means that these people are susceptible to hepatitis B infection if they get exposed. And indeed, there have been several outbreaks now. Among injection drug users, there's been a resurgence of heroin use in North America, in the United States, and the lack of immunity has resulted in a sharp increase in new infections in certain pockets of the United States where injection drug use is common. And this occurs mainly among adults, 30 to 39, for whom there's very few that have been vaccinated with acquired immunity. But if we do it right, we have the means, and if we do it right, as in Alaska, it's been nicely demonstrated that you can actually eliminate hepatitis B. In Alaska, which used to have one of the highest prevalence of hepatitis B within the United States, they now reported no new instance of hepatitis B infection, no new cases of hepatitis B related HCC among children for more than 10 years. So it is possible if we have the will and we do it right. But prevention is not the only thing. As in many other countries, the care cascade for hepatitis B is very disappointing. This is the estimated number of people who are infected, and yet the number of people who are getting treatment is dismally low. So again, we have the treatment. It's not that we don't have the treatment. We have it, and many people have healthcare insurance, but they're not diagnosed, they're not referred to care, and they're not started on treatment. And therefore, the CDC has initiated several and funded several testing and linkage to care programs. But even in these funded, well-organized programs, where a lot of people are screened and some people are found to be hepatitis B infected, you can see that less than half of them get linked to care, get started on, and actually even show up for a medical appointment. So we need to make sure that whatever plans we have are executed down to the last step. Otherwise, the possible goals cannot be accomplished. So what about hepatitis C? So again, there have been a lot of initiatives to reduce the number of hepatitis C cases in the United States. starting from indirect screening of blood donors for ALT and core antibody to implementation of hepatitis C antibody screening and Needle-Stick Safety Act. There has been a dramatic decrease in the number of new cases, but if you look very carefully, towards the last few years, there's been a slow increase in new cases again. And this is showing you in greater details that in the last 4 or 5 years, there has been an increase in instance of new infection again, and most of this is really in the young adults, 20 to 29 and 30 to 39, and this is because of the resurgence of injection drug use. Well, we've heard that in many parts of the world, no one knows exactly how many patients are infected in their country. Well, even in the United States, where we have a lot of surveys, we're not sure whether we trust the NHANES data. So this is actually a recent study looking at, this is data reported by NHANES, which is supposed to be fairly comprehensive. But NHANES, as we all know, does not include the most vulnerable high-risk population. And if you actually do modeling that include these added populations, which include those who are incarcerated, homeless, hospitalized, living in nursing home, in the military, in Indian reservations, it's been estimated that you should add another 1 million that are hepatitis C antibody positive and 800,000 that are HBRN positive. So the real numbers may be much higher than what has been reported and used over and over again. As we've heard earlier, even if there's a true decline in incidence, even if there's a true decline in prevalence, the problem that we are facing is that we now have a higher number of people who've been infected for a long time and have now reached the stage of cirrhosis, as well as having decompensated cirrhosis. So this is estimates from Gary Davis modeling, showing that we're not going to really see a peak until 2020 or 2025. And similar findings have been shown in Canada, where the HCV RNA positive persons, according to disease stage, the more advanced disease stage, continue to increase well into 2030. And here you can see that the proportion of patients with cirrhosis with liver cancer needing transplant will continue to increase all the way to 2030 and will only start to decline after that. So yes, we have a lot of new drugs, and we've all heard of the wonders of the new drugs. We've also seen that these drugs are widely used in North America. So we do have these drugs. They've been available in North America the earliest, and over time in 2014 and 2015, you can see an increasing number of people who have received these direct-acting antiviral agents. But there are still problems. Even in the United States, and many of you have seen these papers, that the most vulnerable who are relying on Medicaid, Medicare, they are people who are not getting treatment because of the high cost of these drugs. The federal health policies have placed a lot of restrictions. Even private insurance have placed a lot of restrictions. Patients need to have advanced fibrosis or cirrhosis to get coverage. Those with early stage of fibrosis oftentimes do not get covered. As a physician seeing patients in the clinic, I constantly have to deal with questions from my patients who ask, if I were to have cancer and I was diagnosed to have stage 1 cancer, you will be telling me, good news, bad news. Good news, you're diagnosed early. Bad news, you have to wait until your cancer gets to stage 4 and metastasize before I will treat you. And that's what we are telling our Hep C patients. So this is the care cascade for hepatitis C. Again, like hepatitis B, estimated number of infected people, but only very few people getting treated and getting cured. And unless we really change that policy, make the drugs more accessible, more affordable, and also find the patients who are infected but not yet aware of the diagnosis. And that's the reason why the CDC has recommended screening of baby boomers, because people born between 1945 and 1965 are most likely to be infected, and they account for 75% of the chronic hepatitis C in the United States. And again, despite the fact that CDC has been funding these testing and linkage to care programs, we find that not everyone who gets hepatitis C antibody positive get RNA testing, and not everyone who tests positive have been referred to care. 83% referred to care, and only 70% actually show up for a doctor's appointment. So we need better education to make sure that people understand. We talk about the differences in age of what the highest risk population is in different countries, and this is some data in Canada, very similar to the United States, maybe a little younger, however, there's no standard policy of screening the highest risk group based on age in Canada yet. So what are we heading for in the United States? The targets for 2020, the CDC hope to increase the proportion of persons who are aware of the infection of hepatitis B from 33% to 66%, and for hepatitis C from 45% to 66%. The goal is to really reduce the number of new cases of hepatitis C infection by 25% and eliminate mother-to-child transmission. And we must account for imported cases of both B and C. Just a few days ago, the Institute of Medicine has released a report with a new initiative to study whether we can eliminate hepatitis B and C in the United States, and there will be a second report in 2017 with specific recommendations for action plan. Thank you.